screen?
Yes, sir. We are seeing your screen.
I'm thankful to the management of fifth virtual in course of Shalamar Medical Dental College. Um, and I'm thankful in particular to Professor Harun Yusuf and Iftikhar Yusuf for giving me such a nice topic, management of ulcerative colitis. We all know that we make mistakes. I don't have any disclosure pertaining to this presentation. And these are the common mistakes. This is a long list. You all understand that with this list, uh, something which we have come across on a daily basis, one patient, two patients, where something we see wrong somewhere, starting from the diagnosis all the way to the management.
Yes,
So
can
these,
you share your screen? Can you share or Ghias?
so can, my screen is not shared?
Yes, sir. Your screen is not.
No, not
Okay,
shared. Up till now, it's
okay,
not shared.
okay. Give me a moment. Okay, so this is the list of mistakes that we commonly make in our day-to-day life. And starting with the first mistake, ulcerative colitis is a disease of the West. Now, this is something which, while growing in this community, starting from way back in early 90s and to 2021, I can see a transformation at a stage when ulcerative colitis was not the initial diagnosis in the clinical units. And now, though clinic ulcerative colitis is considered a common diagnosis in our units, but still in the community, in the GP practice, it is not there. And let me tell you that in a country where we don't have an integrated healthcare system, where we don't have the computerized system, we don't have the exact statistics. The prevalence of ulcerative colitis has ranged from 4 to 44.3 per 100,000 in Asian population, although it appears to be more in the Western population, but Asia is not far behind. In Pakistan, true prevalence of disease is really not known. In a large referral center in Khan, the incidence of ulcerative colitis in patients presenting with rectal bleeding was reported to be as high as 25% by Professor Saeed Wasim Jafri in 2016. And we are trying to make a IBD registry in Pakistan, in Lahore General Hospital, in collaboration with British Society of Gastroenterology. And I request all to collaborate with us once it is in place. Um, Now, is there any particular age where we should expect that ulcerative colitis should be presenting? Generally, there's a bimodal presentation either in the teens or early adulthood, or then later in the age of life above the age of 60. Any ethnicity in Pakistan is vulnerable, although Jewish seems to be more common to be suffering from ulcerative colitis and similarly Crohn's disease. And let me tell you that although it has been an understanding that Crohn's disease is more common in the West as compared to Pakistan, but over the years we have started to see that there are more number of people coming with the diagnosis of Crohn's as well. Male to female ratio is the same, and people who are suffering from people who smoke, they tend to have some kind of protection from ulcerative colitis. Maybe there's lesser severity of the ulcerative colitis. And similarly, appendectomy seems to be giving some kind of protection in these patients. Now, delayed diagnosis is something which is very common. We are a country where we are thinking about infection all the time. But over the years and over a period of time, we have seen that there's a paradigm shift from the infections. We have started to think of the inflammatory disorders and then at the same time genetic predispositions. Meaning by that if one person is suffering from ulcerative colitis in the family, we must be looking for other members of the family as well to be suffering from the same disease. And the paradigm should be shifting from infective like bacterial colitis, maybe colitis to IBD, and then similarly other overlapping disorders like IBS or celiac disease. So this paradigm shift is being seen increasingly over the time. Average delay in the diagnosis of ulcerative colitis is 24 weeks in the Western literature, but in Pakistan, I presume that it is maybe more, roughly 3 to 4 weeks, 3 to 4 years, although I don't have any data on account of that. We don't have any published material on that account from Pakistan. I still remember a patient way back in mid 90s, a person from Burewala in his mid 40s. He was diagnosed to be suffering from ulcerative colitis, and he had been suffering from symptoms for the past good 20 years. And after the treatment, his comments are still there in my memory. डॉक्टर साहब मुझे पहली दफ़ा पता चला है कि नॉर्मल पखाना क्या होता है, नॉर्मल पेट क्या होता है. So if this is the kind of condition, one can imagine the delays in the diagnosis, and this delay in the diagnosis becomes very important because this is directly linked with the prognosis and treatment efficacy as well. If we are able to pick a person early, the chances of responding to the lesser aggressive forms of therapy are more. But if the person is diagnosed late and with more severe disease, the chances to responding to therapy and going on to the colectomy are relatively more. And one can see that with this univariate multivariate analysis, the ones who are diagnosed early and as compared to the ones who are diagnosed late, the severity index and disease extent is always different. Now, basis of diagnosis remains a combination of history. One has to have very clear idea in the mind that any person who is presenting with frequent episodes of loose motions or incomplete evacuation, and in clinical examination, there's nothing to suggest of infection. An endoscopy is required, and on endoscopy, histopathological confirmation is definitely required. In Pakistan, we have grown up with a classical histopathology picture of a mononuclear infiltrate, but over the years, we have seen a clear improvement in the trend. People have started to describe the change of ulcerative colitis on these pathological samples more clearly. Mistake number 3, that we fail to assess the severity score as per guidelines. We tend to fail to understand that every time a patient tends to present, this TrueLove score or Mu score, clinical severity index of ulcerative colitis, needs to be applied. Any patient who's falling into the severe and permanent category, they need to be separated from mild to moderate category, because mild to moderate can be managed in the outpatient setting. For severe to permanent, it's very important that we keep them under close surveillance. We keep them in the hospital till we have achieved the remission. And what is the different types of ulcerative colitis? Maybe a distal disease, meaning by a disease limited to the rectum only. Then left-sided colitis, where the disease is limited up to splenic flexor. Subtotal, where the disease is limited to the hepatic flexor. And extensive, where it is all the way to the cecum. And then backward ciliatis. And we can divide it for the simplicity into 2 categories as well. Limited and extensive. Limited means up to the splenic flexor, and extensive means up to the cecum or into the ileum as well. And then based on the endoscopy, we can divide it into mild, moderate, severe, long-standing disease. And remember that endoscopic picture and the clinical picture has to be combined together in order to make a clear-cut diagnosis, in order to make a clear-cut assessment in terms of what exactly do we have to do to avoid these mistakes, number 4 to 8. There's incorrect management of induction and maintenance, inability to monitor and tailor therapy, failure to provide correct doses of immunomodulators, failure to manage the flares correctly, and failure to initiate biological therapy at an appropriate time, although the only biologic therapy available to us is infliximab at the moment. So number 1, once we have made the diagnosis, assess the inflammatory status, we have to assess the comorbidities and disease and therapy-related complications, stratify according to the colectomy risk. So this is the proposed algorithm by the American College of Gastroenterology, that based on the symptom and signs, these are tests that we need to send for each and every patient. And then sigmoidoscopy is the way to go. It's a quick procedure. It doesn't need any special preparation, and it can be done in a time period as short as 5 minutes as well, along with the biopsies. And then imaging modalities can be used, especially CT with contrast or bare enema, but are they cost effective in our setting? The answer is possibly no, although one has to support it with the data, but this is just my own personal station, that in Pakistan, his clinical examination should be followed by sigmoidoscopy, and on sigmoidoscopy, one should have to have biopsy to confirm it on the histopathology. Now, once the patient has been assessed, we have to stratify whether the person falls into the low risk category for colectomy, meaning by that the person is suffering from limited disease and the disease severity is mild to moderate. And one who may require colectomy and one may need more aggressive therapy are the patients who are suffering from extensive colitis, who have got deep ulcers with lots of pseudopolyps, age less than 40, high CRP and ESR on hematology testing, and the previous history of steroid requiring disease, history of hospitalization, and previous history of severe difficile infection, or on histopathology, find that CMV infection is there. They're the ones who may require endoscopy. I've already said that sigmoidoscopy is a good tool. Now, once we have stratified into the low risk versus high risk, then obviously next thing is, do we need to keep the patient inside the hospital or we can send the patient home? For moderate disease, a patient who is otherwise well without any systemic symptoms, one can manage the patient on outpatient basis. But otherwise, for the people who have got clear-cut symptoms and signs of systemic inflammatory response, in those it is best that the patient should be kept inside the hospital, and particularly if on biochemistry albumin is less than 3 point, they're the ones who should be managed in the hospital. Now, in low-risk patient, what kind of inductive and maintenance therapy are we talking of? In inductive therapy, we have oral 5-aminosalicylic acid, or it may be combined with rectal salicylic acid as well. Do we need to use prednisolone in each and every patient in mild disease? Plus minus, although if the symptoms are significant, prednisolone can be added, but in majority of the mild to moderate diseases, oral 5-aminosalicylic acids are good. In case of not remission in 6 weeks, it is best to go for a treatment algorithm which is reserved for the high-risk patients on the outpatient basis. Maintenance is by and large with the 5-aminosalicylic acid, that is mesalamine. And if the steroids have been given, it is very important that we need to taper off the steroids in the 60 days. In relapse cases, it's very important that we need to investigate the patient properly in terms of disease severity and in terms of other possible diagnoses, which I'm going to address in a short while. In high-risk patients, which is by and large the patients who are to be treated by people who are specializing in gastroenterology or in the IBD, over there, injectable corticosteroids, then addition of thiopurines and biologics, which is not used very frequently. And the only biologic I've already said available in Pakistan is infliximab. The experience is still limited. And we need to learn more about the utility of infliximab in our society and the pros and cons for that. And very important that be careful while giving steroids that in 30 to 40% of patients with acute severe ulcerative colitis, we fail to respond to steroids. So if within the first 72 hours, people don't start responding according to the TULIP criteria or Oxford or Swedish criteria, it's important that we need to go for the next therapy, and that is anti-TNF blockers, infliximab, and instead of delaying it a bit too much. At the same time, it's important that we need to consult the surgeon as well. What are the main side effects of medicine that are used in inflammatory bowel disease? In case of 5-ASA, it's hypersensitivity, sperm abnormalities, and blood discrepancies, mainly thrombocytopenia or leukopenia. In corticosteroids, which are overprescribed, oversubscribed, and over-relied drug, adrenal insufficiency, hypoglycemia, edema, osteonecrosis, cataract formation, proximal myopathy, peptic ulcer disease, low potassium, all these things happen very frequently. At the same time, these patients are more prone to get CMV infection as well. And similarly, we are a society where there's a high incidence of, high prevalence of tuberculosis. We have a high prevalence of hepatitis. So we should be mindful of that. Azathioprine, although people are very afraid of this drug over the years that I've used azathioprine, and similarly, the world has experienced that azathioprine is by and large very, very safe drug, except in the first 2 to 4 weeks, where in those people who've got a tendency to develop leukopenia or bone marrow suppression because of azathioprine, they tend to present, they may present with significant anemia or a problem related to the leukopenia. Metronidazole, which is again used very frequently, one must remember that in people, unless we have a definite evidence of infection, it should not be used. And alpha inhibitors, TNF alpha inhibitors like infliximab, anaphylaxis at the time of infection, superinfection in the form of CMV or Clostridium difficile infection should be considered. Chest pain or rash, risk of reactivation of tuberculosis, they all remain an possibility. And once again, an important message: one should not miss CMV and Clostridium difficile, not just in people who are suffering from ulcerative colitis and dependent on corticosteroids or using TNF blockers, but in all other patients as well. So every time a person presents with a flare, it is important that we should be checking Clostridium difficile toxin, and we should be looking for CMV infection as well on biopsy as well as on the histopathology. This is a proposed management algorithm by American College of Gastroenterology. It's a very comprehensive slide, and important thing is that in active disease patients, one needs to keep these patients on follow-up every 3 to 6 months, in remission every 6 to 12 months, and one needs to apply the proper guidelines to these patients. And this is a very good proposed algorithm, again by American College of Gastroenterology, that we need to have importance on the clinical targets, and then endoscopic targets, then histological targets, adjunctive biomarker targets. In this regard, I shall emphasize on fecal calprotectin, although it is still very, very expensive in our society. One test costs roughly about 5,000, and we get the result after 48 weeks. But as the price comes down, this will become a very important tool in monitoring the patient, although at times we find it difficult to apply the results of calprotectin levels. When the calprotectin levels are higher, all the symptoms are very good, one starts becoming uncomfortable in escalating the dose, and then obviously the novel markers. Now, a very important thing in our society: what does the patient like to eat, and what's the nutritional status of the patient? These are two different things. Food beliefs is a different thing. Nutritional requirements of the patient is a different thing. And it's very important that caloric replacement in a patient who's suffering from acute ulcerative colitis, acute severe ulcerative colitis, and in a patient who's suffering from ulcerative colitis but in remission should be kept in mind. Adequate protein, at least 1 gram per kg, has to be given. And adequate calcium replacement and vitamin D is definitely required in these patients. And during active disease, it's important that small frequent meals with low residue content but adequate calories, they are very, very important. And let me remind everyone that most of the high calorie diet, including fats, they get absorbed in the proximal gut. So small frequent meals of any kind, they can be given to these patients. During remission, there's no special diet in these patients. One common myth: milk and dairy products. There's lots of confusion about milk country, especially in the villages, where people cannot live without milk. Unless a person is lactose intolerant, milk and dairy products can be consumed as per routine. There's no data available till to date where milk and dairy product avoidance is of any kind of help in terms of improvement in the ulcerative colitis, in terms of reduction of the symptoms. Now, mistake number 9: surgery is acceptance of failure. And this is something which we all clinicians must understand, that surgery doesn't mean that we are accepting the failure. It is one of the treatment option. And this treatment option should be offered early to the patient, especially for the patients suffering from acute severe ulcerative colitis, the patients who have deeples and pseudopolyps, the people who are suffering from frequent flares, complicational disease. And at the same time, in our society, we should be mindful of the cost of the therapy as well. Mesalamine costs a lot. Not every patient can afford the mesalamine. Similarly, infliximab is very, very expensive. coming to the hospital, staying in the hospital, irrespective whether it's a public hospital or it's a private hospital, again, it costs a lot. And the people who are not compliant to the drug, either because of the psyche or because of the affordability, they're the ones who should be offered the surgical remedy early rather than late. And then, final, when should we discharge the patient? One must remember that discharging the patient too soon is going to be counterproductive. It's very important for us, the clinicians, in the absence of a clear discharge criteria for patients who are suffering from ulcerative colitis and hospitalized, at least the person should be significantly improved clinically. There should be no tenderness. The biochemical markers uh, tend to take time, but hematological markers should be monitored to such an extent that there should be a significant degree of confidence that the inflammation, systemic inflammatory response has been taken care of, and the person is in a good hydration nutritional status before we send the patient home. And it is very important that before we send the patient home, we should make the patient understand that he has to come back, and this is a disease where the person has to live with it. This is a disease where the person has to continue taking therapy for the rest of his life. It's not that we can cure the disease. We have to continue the treatment for lifelong. And with this, I thank you for your patient listening.
Thank you, sir, for such a